Okay, so today we're going to talk about health economics. So the three parties, it's pretty straightforward. I know you've got some other components to this week as well, so I'll keep it brief. Three parties to health economics. You have the consumer, the patient, the payer, the employer, the insurance company, and then the providers, nurse practitioners, docs, whatnot. So those are the three key players. Factors that affect the cost of healthcare are things like DRGs, drug diagnosis-related groups. ICD codes doesn't really affect it, but that's an important one to know because it kind of is related to DRGs. It's how insurance companies bill. I'm sure you've all dealt with that. Then we have fee-for-services and negotiated case rates. Just important to note, this is the last factor, it's important to note that health insurance is not so much a consumer-driven, like pretty much every other kind of market or economy. It's kind of provider-driven. Where the docs want to be is where their services are going to be, regardless of if they have many patients elsewhere. So that's just important to note. However, we're kind of moving towards that more of a consumer-driven, and hence all the quality and to make it marketable. So basically, I've got this little slide here. I've got a little two-slide slideshow. Just kind of break it down. It's kind of confusing when you try to learn all the insurance. So I just kind of break it down. It helps me because I'm a visual person. So you have the fee-for-service, like I mentioned, ICD codes. Fee has to be appropriate for the ICD code or the insurance won't pay for it. Fee-for-service, the doc gets paid no matter what, so there's no risk. So there's actually incentive for more testing because the more they do, the more they make. And then the last thing with that is if you've ever worked with case management, advanced billing notice and ABN form, I hear that thrown around a lot. If something's not going to be covered, you need to inform the patient. And we do it a lot with overnight stays. Patients feel like they want to stay, and the docs tell them, oh, you can stay if you want. And then we have to go in and tell them, or the case management tells them, you can stay, but you're going to be paying for it. So the prospective payment system, PPS, is a flat rate per ICD episode, so per episode of heart failure, per episode of heart attack, diabetes, exacerbation, whatever. You get money to decrease the testing because you're only getting so much regardless of how much you do. So what we do here is we try to increase the number of patients we see. We can do the same amount of care in one day and get them out and then get 5 more patients in. We make 5 times as much as if we have the same patient for 5 days. And then the capitated, which is where it gets kind of hairy here. The capitated system, flat rate per patient per month. This applies more to primary care physicians and hospitals as far as Medicare patients, Medicare, Medicaid patients. So the incentive here is to keep healthy patients. Preventative care is a big thing. And then this is just important to keep in mind because I'll kind of throw back to it, but incentive to deny sick patients or to deny services. And I'll mention later on, but they have peer review groups to kind of make sure that doesn't happen, that we're not denying services that people need. HMOs are a type, and this is all managed care. So HMOs are a type of managed care. They focus on prevention. They're marketable based off what kind of relationships they have. So they have an incentive to kind of get with the best docs and hospitals in the area. 4 different models there, and I'll let you look at those in the book. Staff model, group model, and individual provider association and network model. Those are pretty straightforward in the book. Then the point of service. The point of service plans are a lot like the network model of an HMO. So the PCP gets a capitated rate per patient per month. They're the gatekeeper. You need a referral from them to see a specialist. If you go to an in-network specialist, it costs the patient less money because they have a negotiated rate with the insurance company. So the insurance company pays less, and then in return they keep a flow of patients going in to the specialist. However, if you want variety, you can choose that network. You just have to pay more. And then the preferred provider organization, insurance bears the risks. They contract with, this is kind of more like the group model. They contract with hospitals, and the group model of the HMO. They contract with the hospitals and docs Again, discounted fee-for-service rate. In return, the docs and hospitals get more patients from this insurance company. The difference between the group model and the staff model of an HMO is basically this: is a group model is kind of a contract, and the staff model is their salaried employees of the insurance company. So one has a little bit more leniency, and one is in turn a little bit more stricter. The staff model is more stricter because they're more controlled by the insurance company. So that's basically a rundown of insurance. It is pretty confusing. Then quality. Oh, I don't know, the slide's not changing. There we go. Quality. Everything is kind of interrelated. Quality affects economics. Economics drives quality. So the big players, again, Center for Medicare Services, the IOM, the Joint Commission, and national data. I don't know how to get that to go down, but the national data for nursing quality and indicators. I can't get rid of that little thing. I've tried forever, but it's there, I promise. So the Center for Medicare Services, what they do is they do pay for performance. So based off how well hospitals are meeting quality indicators and meeting standards of quality as outlined by CMS, they get paid. And what will happen is, based off of how well they do in the scores, if you ever work at Eastern Maine, you hear everything about our scores. Based off your scores, you get paid so much. You don't get paid automatically 100%. They'll take so much off the top. And then based on how well your scores are, you may get some or all of that back. Cost sharing, you can choose to elect to go into a quality program to participate in the quality measures, like I mentioned before with quality and safety snippet there. If you choose to participate with quality measures, then based on how well you're meeting those, and if you can control cost, this gets confusing, so I'm going to slow down here. So they get a capitated rate per patient, and if they can still maintain the quality measures and keep it under that capitated rate, the CMS will, whatever they've saved by staying under the capitated rate, they will share that with the hospital. So the hospital has an incentive to stay under the capitated rate as well. Then the peer review groups, like I mentioned, just because there is an incentive here to deny sick patients because you want to keep them healthy. We just have independent peer review groups that the CMS contracts with, just to make sure that they look at utilization and basically review the charts and stuff, and just make sure that people aren't getting denied care that they need, and that docs and hospitals are working as efficiently and economically as they can. For the Joint Commission, they do have report cards and health grades. That's just more or less because it's getting to be consumer driven and people have choice in care. And then the National Database of Nursing Quality Indicators here, they have what's called the Magnet Recognition Program, and that's kind of like back to the consumer driven. It kind of just gives another seal of quality, kind of attract customers and patients. Institute of Medicine, they're just kind of there. They're the overarching thing that they come out with the reports of how we can improve quality. And then Maine Quality Counts, that's kind of like the IOM of Maine. They are another group of professionals that they kind of come up with, hold forums and conferences and come up with, hey, how can we make care better? And then they kind of work with hospitals, docs, and they also encourage education, like the DO school down in Portland and the nursing schools. They kind of encourage quality, the education topics and quality. They kind of monitor and encourage that. Then the last thing to talk about is just access to care, improving access and containing costs. So obviously Obamacare, I don't know if you did anything with Healthy People 2020, that's one of them, but Obamacare, Medicare, they're expanding that or trying to. The CHIP program, which is basically Maine Care for Kids. And then the Certificate of Need, that's basically to kind of keep costs of the hospital down. If the hospital wants to make a major purchase or build a building, like say they want to purchase an MRI machine, they have to get a certificate of need approved by whatever board, usually by whatever board it relates to, and that's kind of held by the government. And that's just to kind of keep hospitals' costs down, because they're obviously going to pass their costs on to patients. And the DRG groups, like we've been mentioning, those are kind of came in response to out of control use of fee-for-services. DRGs are a product of the Medicare. Those are Medicare patients. ICDs are everybody. Those are insurance. So that's basically it on economics. Basically, it's insurance, and then how does quality tie back into the economics. And I'll put these slides on Canvas.